This is Radio Health Journal. I'm Reed Pence. This week, how coronavirus may affect your local hospital forever.
I worry. I think there may be some hospitals who are going to have to go bankrupt.
COVID-19 and healthcare finances when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
Flying a drone over public space like a beach or a public square and using the drone's loudspeaker to tell people to go home.
The many uses of drones, from private flight to protecting public health. Then
they revealed to me that my father had not been my biological father, which is something that I had never remotely thought, known, entertained.
The hidden secrets uncovered through at-home DNA testing kits. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
As COVID-19 cases continue to mount, many hospitals in hard-hit areas are struggling to find enough beds, ventilators, and protective gear. The care patients require is difficult, time-consuming, and expensive. The federal stimulus package, the Coronavirus Aid, Relief, and Economic Security, or CARES Act, anticipated all of this.
Even though the CARES Act allotted $100 billion towards healthcare providers to compensate them for the expenses that are going to occur because of COVID-19, it's not going to be nearly enough to cover the losses they're going to experience.
That's Dr. Vivian Ho, Chair of Health Economics and Director of the Center for Health and Biosciences at Rice University and Professor of Medicine at Baylor College of Medicine.
Unfortunately, we don't have an estimate of the total cost. We haven't had a chance to sit down and do that. But my guess is, say, another $100 billion is not going to be enough, and it's all going to depend on how long this pandemic continues for.
We're concerned that even with the most recent CARES Act, that our hospital systems and our physicians are going to be under-reimbursed for COVID care. And we're trying to do, as a healthcare system, actions that will allow us to have more bed space and more resources to protect both the patients and the healthcare workers. But in doing so, we are going to be putting the healthcare systems at financial risk.
Dr. Heidi Russell, an associate professor at the Baylor College of Medicine, is co-author of the analysis.
There is a cost, without a doubt, to preparedness and the steps that the healthcare system is having to take. And then there's a cost to learning as we go along from this particular event. And then there are the hidden costs that nobody was expecting.
Among those costs you might not think of is administration for an extremely complicated response. Ho and Russell say that normally administration runs at about 8% of healthcare costs. Now it's much more than that.
Hospitals are having to completely reorganize themselves to prepare for COVID-19. So they're talking about acquiring new hospital space. For example, here in Houston, we just got a notice they're planning to take over the lobby of the hotel next door if they have to. So that factors into administrative costs. They have to start training personnel in additional new skills and scenarios that they hadn't prepared for before. And they're having to spend more energy looking for PPE, ventilators, all the additional equipment, plus the drugs that they need. And so that's all in terms of administration that doesn't really occur on a regular basis and didn't occur in hospitals before the pandemic started.
And while insurance might not pay for administration if those costs are running high, a hospital might expect it would pay for treatment of an insured patient. But Ho says that's only sometimes true.
It may be possible to have most of these expenses covered by private health insurance, but it is surely not going to be the case, for example, for Medicare patients, where Medicare reimburses hospitals by the diagnosis-related group system. So they set a fixed fee for every single type of admission. And if you look at the standard types of diagnoses that patients are going to have with coronavirus, it's things like pneumonia, acute respiratory distress syndrome, sepsis. Those reimbursement rates aren't all that generous simply because they're not the ones that involve very, very high-cost procedures. And so usually that's where hospitals get a lot of their revenue from Medicare, from doing, say, an operation like open heart surgery. There's not that type of an operation going on for COVID-19 patients.
And with healthcare providers bidding against themselves for supplies like ventilators, the costs are going through the roof, while payments may remain at a flat rate for whatever a patient with pneumonia would bring.
Pneumonia no longer costs what it used to cost because now our healthcare providers are donning PPE money, and the time it takes for the providers to do it costs time and money. And so there's additional costs on top of that, plus the costs of things like running these command centers and preparation.
When you think of pneumonia patients, you usually don't think of most of them requiring a ventilator, and I don't have the numbers on the exact percentage, but clearly it's a higher percentage of patients requiring things like ventilators, which is more expensive equipment and more time from a respiratory therapist. And so these are going to be the losses that are occurring. Plus, a diagnosis-related group, those costs are predicted based on an estimated length of stay in the hospital. And it's turning out that the lengths of stay for COVID-19 patients are longer. It's taking them longer to recover. And so that's another factor that's going to drive up the cost that is not paid for in Medicare patients and actually not necessarily paid for in some private health insurance reimbursement prices as well.
Those losses will be big enough, but Ho says where healthcare providers will lose even more is from procedures and surgeries classified as elective that have now been canceled.
Our healthcare providers have shut down their elective care. So they're experiencing losses as much as 50% of their revenues on a daily basis because they are trying to reduce the spread of the virus, and that's what's going to be the major loss. What people don't realize is a number of elective procedures are actually highly profitable for hospitals. So things like joint replacements, cardiac valve replacement surgery, those are the types of things where a hospital can actually make a very large profit, and that profit then subsidizes many of the things that are money losers for hospitals that they still need to provide to keep the community healthy.
Lost opportunity brings up a number of issues because it's a lost opportunity for patients as well as hospitals, and it may have long-term consequences as well. When you hear that it's elective procedures that are being canceled, that doesn't mean just things like hip replacements and plastic surgery. It can also mean heart surgery, cancer surgery, and chemotherapy. They may not be emergencies yet, but putting them off may still cost a life. And Russell says even minor procedures can have a high human cost if the patient doesn't come back.
Depending on what the problem is that you're getting them in for, like if it's a hip replacement or a knee replacement sort of thing, well, they're in pain, most likely, so pain will continue to trigger them to want to get the procedure. If it's something like a colonoscopy where you've encouraged them and, nobody wants a colonoscopy. And so you might have gotten that scheduled and everything set up, and that getting them rescheduled is going to be a big challenge. So we may never get those people back in, or they come in a lot slower. And if they come in a lot slower and it's preventive care, my other concern is if you postpone that, they may be coming in with colon cancer later, or they may be coming in with a much more difficult to repair hip. And so we may not get them in, or we may get them in with a much more significant procedure requirement or medical care delivery that's required.
For physicians, there's a cost as well. The cancellation of their elective procedures has cost some their jobs, ironically in the midst of an enormous need for doctors elsewhere to take care of COVID-19 patients. In postponing non-emergency care, hospitals have kept people safe and cleared beds for coronavirus patients. But it'll hurt some hospitals a great deal to do it. Ho says smaller ones will be hit hard when they can't ship out COVID-19 patients anymore.
We still have capacity at the higher skilled teaching hospitals, and they will take the most severely ill patients as long as they have room for them. And so I think they're going to bear the higher cost of these more difficult patients because they have, costly specialty rooms. They can have negative airflow pressure rooms and things like that a smaller community hospital doesn't have. However, if it gets to the point where the major teaching hospitals are completely filled up, then unfortunately you're going to have burden being placed on smaller community hospitals and rural hospitals. And that will be not only a financial stress, I don't think they're going to be able to get a lot of the equipment and a lot of the specialty care. They're not going to be able to provide it, but it's just going to be a psychological toll on those providers as well.
Not every hospital or healthcare system is going to come out of this looking like it looked going in. There will be some type of hospital that is going to do badly. And that's certainly not to say all hospitals are going to fall apart and we'll lose our healthcare system entirely, but that would be like absolutely worst case scenario, and that would be the least of our problems in the United States if that were to happen, because the whole system would have tanked. But I think that some hospitals will be in serious trouble, and that will be really unfortunate, because any hospital that's able to provide the complex care that some of these patients are going to need are serving quite a few patients with a lot of other needs.
In order to survive, it's economically important for elective patients to come back. However, Ho says they may come back too late.
My guess is that a majority of the health care will be deferred, and it will eventually be provided by healthcare providers. However, the hospitals will be sitting there looking at second, third quarter significant losses, which they are not going to be able to recover. And many hospitals, for example, have taken out bonds to pay for capital investment and things like that. So they've got salaries, they've got payroll to meet, and they've suffered huge, significant losses. So I worry. I think there may be some hospitals who are going to have to go bankrupt to cover these issues unless there's more intervention at the federal level.
However, some critics wonder if hospitals and the healthcare system really deserve an even more enormous stimulus package when they already have so much of our money. Ho says it's true that costs have been too high, but letting providers go bust after risking their lives to save others isn't the way to drive costs down.
Look, a lot of people are going to say, why should we be reimbursing hospitals for this extremely high amount when they were asking too much money from us already? The problem is you can't just then say to every single person who's been making money off of the healthcare system, that's it, you're not going to get it. If we do that, we're going to suffer a complete halt in healthcare providers' willingness to serve us. I don't want the hospital thinking about whether they're going to go under next year or not, depending on how they treat the next patient, the next COVID-19 patient who's coming through their doors. So, yes, we have to have an important discussion about getting healthcare costs under control, but let's try and deal with this particular crisis now, make sure our hospitals have adequate funding so that they can care for the patients that we need them to care for, and because it's likely that this could occur in the future, and we want to make sure that hospitals and physicians respond well if this happens again.
You can find out more about all our guests on our website, radiohealthjournal.org. I'm Reed Pence. Americans are taking sheltering in place seriously. During the week ending March 15th, when social distancing first started to take hold, produce sales were up 40%, and potato sales were up more than 72%. Columnist Produce by Pamela says that's because people are filling pantries for the long haul. Frank Muir is president and CEO of the Idaho Potato Commission.
Potatoes have a long shelf life, but as with any produce, it's dependent upon how they're stored. Potatoes should be stored in a cool, dark, dry place, but not in the refrigerator. The cold converts the starch to sugar, which creates a sweet flavor. Also, don't wash your potatoes before storing them, and don't store them near onions. Finally, if your potatoes sprout, that's okay. Just pick the sprouts off and your potatoes will be ready whenever you need them.
Staying in also means you'll need to cook with ingredients you already have on hand. You'll find recipes with that in mind at idahopotato.com. That's idahopotato.com.
And that's Radio Health Journal for this week. Radio Health Journal is a production of MediaTrax Communications. Follow us on Twitter, Facebook, and Instagram to learn more, and check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.
Coming up next week on Radio Health Journal.
We're getting on top of the situation. All of us doctors are asking people to just hang in there and watch ourselves succeed.
Getting impatient with social distancing.
Then creating guidelines over which patients get ventilators and which ones don't.
The goal of this framework was to allow doctors to continue on in that role of a faithful advocate for their patients and have a separate group that is making these really tragic choices.
All that and more on Radio Health Journal